Thank you, Priya, for having me in this prestigious course. Incidentally, I'll be showing something similar to what Dr. Biswas has shown, just that the two PPCs where you put the lens, this will be the multi-piece lenses. Now he has shown single piece very beautifully how to put it. Now this is the first video. This is a, yeah. So this is a PPC, as I'll show a part of the surgery when the, this is somebody who I had done around 5-6 years back. I'll show the second eye also is landed up in the PPC. Now this is what I did, what was needed, the inside out hydrodelineation, and I can see I have separated the central nuclear. This is all going okay, nothing wrong. And then taking out the central hard core. It's not that hard, rather soft core, and then getting out one edge out. I think we went wrong. Yeah, this is continuation of that. You can see the central core nuclear hydrodelineation done. So this is a soft, and I'm just getting it out. It's low vacuum, very little power or no power, and then get one edge out. And this is when things might go wrong. At this, I'm trying to rotate it, getting the other part. This is the hardest part, and this is where somewhere I realized that there is a rupture there, and what to do from here, not to allow the vitreous to come in the anterior chamber. The thing that is advised, put in a high molecular viscoelastic. In this case, viscoat is used to tamponade that area. And what I did 5 years back, I would not do it today. I just tried to increase the incision length to around 4 millimeter and try to do a visco expression. Now this is very important if you are doing visco expression, not to allow the rupture to increase. So don't put pressure on the posterior lip. Probably there was some pressure on the posterior lip as I'm taking out. So always fill it with viscoat and visco, and then try to push the anterior part and taking out. And now I'm doing dry aspiration. You can see, I'll show you the rupture as it comes, and putting in viscoelastic from the right hand, and the left hand I'm doing just the dry aspiration, not putting in the fluid but methyl cellulose. This is the technique I follow, and look at the horizontal rupture there. So this is the situation. Now you have an option of putting in, still now I don't think there is a vitreous, but when the vitreous will come, I'll show you. This is, I decide to go in with the multi-piece lens, and again going through the multi-piece lens, again around this stage the vitreous does come out. You can see the as I am trying to put it from a bigger incision, so there's a bit pressure, and I just do a bit of anterior vitrectomy there, and then I should have stained it, but not doing from the same incision. Look at the rhexis margin there as I go to the side, and then I push the lens so that it is captured posterior. The lens is, the haptics are in the anterior on the rhexis margin, and the lens goes posterior behind the capsular margin. This is the second case done on a 6 months, same patient 6 months back. Again, trying to size up the rhexis just around 5 millimeters, so that when you want to do rhexis, you want to do a optic capture, is very important, just around 5 or less than 5. If it is around 6 or less than 6, the optic capture won't work, it will come out. And this is again a harder cataract. I'm using the phaco tip, as you can see. And at this stage, somewhere again, I feel that I'm conscious that this is the second eye of this patient, so I definitely meet some sort of weakness or rupture in this case also, just doing the bimanual IA. As I'm doing the bimanual IA, I realize, yes, there is a rupture somewhere here. This is not the horizontal, the vertical rupture. And here, I don't do the technique that I did earlier, just do push in viscoelastic from the left hand and go on sucking those remnant cortical matter, because they are soft generally in PPC. See, you can, I've got this vertical rupture, and gradually trying to pushing in viscoelastic, and then with the right hand and gradually follow it up the other side. At all time I'm trying to maintain the chamber, not allowing the chamber to break. And this is important. If you allow the chamber to break or chamber to shallow, that's when the vitreous would come out. There I push in viscoelastic and then put in this lens. Again a multipiece. I'll try to capture it on the rhexis margin, and this, the incision being as it is, so there's no escape of viscoelastic. So I had the chamber, and I presume there are a lot of methyl cellulose oil, so I try to push and get it in the center, and then check it with triamcinolone, and I find there's no vitreous there. The iris, the pupil becomes round, and that is how could avoid getting vitreous in the anterior chamber. Now this is a small clip again, white cataract post IVTA. So I thought probably there is some rupture there as I tried to separate the nuclei. I was not aware that it was there, but then suddenly I saw that there is a rupture there, and putting in viscoelastic, as Dr. Biswas has shown, take out your optic, and there is the big rupture which was already there, and putting in the multipiece lens, again rotating it on the sulcus and then capturing it, doing the anterior vitrectomy, going back and clearing up the vitreous there, and then and the last clip would be a lens that has gone back there. This was the quality is not that good. It's done quite long back. This is a single piece PMMA lens that has gone behind. I'm trying to get it out. Now this cannot be done just like that. If you pull it there, there is always a chance of, so there I'm trying to hold it and do a limited vitrectomy there behind the lens, trying to separate whatever is. Ideally should be done by a posterior segment surgeon, but you can also attempt it. See, I'm trying and rotating the lens and getting it over the iris first, just rotating it over the iris. The haptic goes, and the other haptic is also rotated, and then I can, if you can see, this is the rhexis, the PCR area from which the lens went behind, and then gradually getting it up and then putting it in the sulcus and doing the same thing with the other haptic. This is something like 10-year-old or 12-year-old video, I can see, and then following it up with anterior vitrectomy. Those days we didn't have the concept of tricot putting in, and then complete the case. Thank you for your patient hearing.
Ajoy, for showing us some videos and wonderful tips how to go ahead with these intraocular lenses and in